So you can have cortisol excess exogenously, and this is the most common cause of Cushing syndrome. Exogenously, nag-inom lang tayo ng synthetic glucocorticoids. This can happen, why? Because you're being treated for an autoimmune or inflammatory problem. Binigyan ka ng steroid, asthma, lupus, etc. Or you go to your friendly Mercury drugstore, and then you go there and you ask, nangangati ako, mayroon akong allergy, can you give me something? Then the pharmacist will give you a synthetic glucocorticoid. They shouldn't do that, no, but they do. Okay. So bibigyan nila yun, or may nagrekomenda sa'yo, inumin mo to, blah, 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 blah. Okay. So once you drink it and it works, every time you will experience similar symptoms, you keep drinking it. Diba? You might even feel, ay, tumataba ako. Diba? And gusto nila yun, bakit kaya ako ayoko na? Pero gusto nilang tumaba, and they sometimes eat it to get fatter. Diba? Okay. So this is your exogenous Cushing syndrome, the most common cause of Cushing syndrome. But for others, it's a true hypersecretion of cortisol. This is an endogenous cause of Cushing syndrome. How can you get excess cortisol endogenously? One, you have a tumor in your adrenal cortex which produces cortisol. Or you have a pituitary tumor which produces ACTH. Or kawawa ka naman, you have a cancer somewhere which ectopically produces ACTH, the most notorious of which would be your lung cancer. Okay. So if you know what cortisol does, begin to imagine what would happen if you had too much of it. This is a typical fasces of Cushing syndrome, and if you develop a clinical eye, if you see someone like this, you will suspect Cushing's right away. First, your cortisol is a glucocorticoid. It increases glucose, promotes lipolysis and ketogenesis, and breaks down protein, and decreases muscle mass. Okay. So when you check the blood sugar, they have high blood sugar. Okay. When you check their arms and their limbs, they're very thin. Kasi nadi-decrease na yung muscle mass, there's muscle wasting. I told you that there's increased lipolysis, right? So there's breakdown of fat. But in the presence of excess cortisol, you break down the fat, but deposit that fat centrally. Kawawa naman sila. So there's central fat deposition. So if you look centrally, malaki yung face nila, they have moon fasces. If you look at their tummy, large, truncal obesity. And if you look here, at their nape, meron silang bukol dyan. This is known as a buffalo hump here. Or if you look above their shoulders, meron tayong supraclavicular fat pad. Okay. I told you also that cortisol decreases connective tissue and collagen formation in the skin. And if you have excess cortisol, this makes your skin very sensitive. And if you look, they can have non-healing wounds. They can have these easy bruisability and ecchymosis or bruises, and the skin is very thin. Diba, you stretch the skin in your abdomen because nagkaroon tayo ng truncal obesity. You form these typical stretch marks, which are very thick and red. Okay, these are very typical of Cushing syndrome. So they're very red and angry looking and thick. Okay. Remember when I said that when you have excess cortisol, what happens is, diba, yung cortisol natin increases osteoclastic bone resorption and inhibits bone formation, such that in the presence of excess cortisol, you get osteoporosis. Okay. And, diba, I said that if you have excess cortisol, not all of it will be degraded to cortisone in the kidney by your 11-beta-hydroxylase enzyme, beta-hydroxysteroid dehydrogenase enzyme, type 2, in the kidneys, and therefore some of that excess cortisol can sit or attach and activate an aldosterone receptor. Because of this, they will retain sodium and with it water, and they will increase their blood pressure. They can present with hypertension or even hypokalemia, low potassium. So there are other effects which are shown here. If you have excess cortisol, you block various pathways in the inflammatory response, and therefore you also block synthesis of all prostaglandins. Some of these prostaglandins, however, are protective dapat to the gastric mucosa, and therefore in the presence of excess cortisol, you can get these GI ulcers or hyperacidity. Such that, in the presence of excess cortisol in picture form, this is what you would look like. Swerte pa nga siya, wala pa siya ng striae na nakikita. No? How do you treat Cushing syndrome? Of course, it depends on the etiology, so you address the cause. From excess, we'll go to deficiency. If you have primary adrenal insufficiency, also known as your Addison's disease. You have failure of your adrenal cortex to produce all your adrenocortical hormones. This can be an autoimmune process such as your Addison's disease, or sometimes an infection can cause adrenal insufficiency, primary adrenal insufficiency, by destroying the adrenals, or a malignant process can involve the adrenals and destroy it and impair its ability to produce the adrenocortical hormones. And slowly, you develop low levels of cortisol, aldosterone, and adrenal androgens. So if you have glucocorticoid deficiency, how would that manifest? All you need to remember are what are the effects of your cortisol and remove those effects. Since you have low glucocorticoid, of course, you get hypoglycemia, low sugar. They don't feel well. This is a stress hormone you needed to survive. So in its absence, you have anorexia, malaise, muscle weakness, nausea, and vomiting. And you are unable to respond to stress. This may give rise to a life-threatening low blood pressure or life-threatening hypotension. This hypotension or low blood pressure does not respond to fluid hydration or resuscitation, as well as giving initiation of pressors, which are basically inotropics, which potentiate your heart to increase the pumping. No? If you give, let's say, a synthetic norepinephrine via the IV, even if you give the synthetic norepinephrine via a drip, or you hydrate them profusely, the BP will not increase. This is known as an emergency, acute adrenal insufficiency. The only way to treat it is to replace the glucocorticoid. And you need to recognize this, or else your patient will die. They have hyperpigmentation of the skin because if you have low cortisol, you stimulate ACTH secretion. In the ACTH, you have that MSH component that we discussed last meeting, which increases stimulation of your melanocytes to produce melanin, and they become dark. If you lose your adrenal androgens, boys, you will not miss it, right? But girls, though we might not miss it, we will know definitely it's gone, because we will have no pubic or axillary hair. You may also have anemia because of the loss of androgen effect. If you do not have aldosterone or you lack aldosterone, what will happen? You cannot retain the sodium, you pee it out. If you pee out the sodium, you pee out the water. You do not pee out the potassium, you retain it even if it keeps going up. And because of this, these patients pee out the sodium, and with it the water, they become dehydrated. You check the sodium levels in the blood, mababa siya because you peed it all out. You cannot secrete the potassium, you retain it. The potassium goes up, you have hyperkalemia. And because of the dehydration, on top of the adrenal insufficiency with the lack of cortisol, you have hypotension, which can lead to shock. Remember when I told you that in the presence of aldosterone, you are supposed to reabsorb sodium, the lumen becomes negative, you pee out H+. Since you do not pee out the H+, you retain it, you have metabolic acidosis. The treatment of all of those is just to replace, right? We'll replace the cortisol via synthetic glucocorticoid, and we can replace with a synthetic mineralocorticoid. Yung adrenal androgen, pabayaan mo na. Next is your classical congenital adrenal hyperplasia. This is a genetic defect involving one of the enzymes, having a deficiency in one of the enzymes anywhere in this biosynthetic pathway. The most common enzyme deficiency usually is a 21-alpha hydroxylase deficiency. Let's locate it here. If I remove that enzyme, I cannot produce cortisol, I cannot produce aldosterone. Since my cortisol is low, my ACTH goes up. And remember when I told you that in the long term, your ACTH increases the number of cells and the size of the cells in the adrenal cortex. This leads to adrenal hyperplasia. Since you have all of this pregnenolone and progesterone, which cannot be converted to cortisol or aldosterone, they are preferentially shunted towards the formation of adrenal androgens. And because of this, you have a virilizing condition. So you may have premature puberty in a male. In a female, you may get virilization or even ambiguous genitalia in the neonate. Okay. Aside from the fact that it is salt-losing because you don't have aldosterone. I think Dr. Rabi discussed hyperaldo with you, so super galing na kayo sa hyperaldosteronism. Okay. So as a review, since you retain the sodium and with it the water, you increase your extracellular fluid volume and increase your blood pressure. You have hypertension. Since you retain the sodium, but with it you excrete potassium, you develop hypokalemia. Since you reabsorbed all of the sodium, the lumen in the tubular lumen is negative. It drew out all the H plus in the through the intercalated cell. Since you pee out the H plus, which is an acid, you develop metabolic alkalosis. If you have primary hyperaldosteronism, meaning a tumor in your adrenal cortex which secretes too much aldosterone, if you have too much aldosterone, your BP goes up, you retain a lot of fluid and sodium, and your potassium goes down. You remove all the stimulus for renin, and you suppress renin secretion. So when you check, the aldosterone is high and the renin is low. And in fact, this is the sine qua non for the diagnosis of primary hyperaldosteronism. We actually compute for the ratio of your plasma aldosterone concentration and the plasma renin activity. It should be high. High aldosterone to renin activity. Do you have questions regarding the adrenal cortex before I move on to the medulla? So for the adrenal medulla, this should be quick for you because Dr. Valenzuela extensively discussed the autonomics with you. And I presume you know this very well already. But in the medulla, you have endocrine cells known as your chromaffin cells, which are which synthesize and secrete your catecholamines. Your chromaffin cells are specialized postganglionic sympathetic neurons, and therefore right away, being a postganglionic sympathetic neuron here, you know right away that there's only one thing which can trigger the synthesis and release of there's only one thing which can trigger the release of your epinephrine and norepinephrine from the adrenal gland, and that is your acetylcholine. Okay. So, this is again from boron. Here you have the biosynthetic pathway for your catecholamines, which I show here in a picture form. The catecholamine synthesis and release in your chromaffin cells involves a translocation of these intermediary products in the biosynthetic pathway between the cytosol and these vesicles in your chromaffin cells known as your chromaffin granules. These are dense granules, dense because of the presence of this protein known as your chromogranin, which has high density. Okay. All your catecholamines are synthesized from tyrosine. They are amino acid derivatives that function like peptides. So we begin first in the cytosol of your chromaffin cell. Here you have your tyrosine, which is converted by your tyrosine hydroxylase to your L-DOPA. Still in the cytosol, your L-DOPA is converted to your dopamine by your amino acid decarboxylase. Your dopamine then needs to enter this chromaffin granule, which is a secretory or storage vesicle here in your chromaffin cell. To enter this chromaffin granule, it makes use of this transporter, which is your VMAT1, or your vesicular monoamine transferase 1, which basically exchanges 1H plus for the entry of a catecholamine. So, opposite directions yung catecholamine in the H plus. And in this direction, dopamine enters in exchange for the extrusion of an H plus ion. Here, in the chromaffin granule, dopamine is converted via dopamine beta hydroxylase to your norepinephrine. In most postganglionic neurons, we stop here, in the periphery. But in the adrenal medulla, you have the last enzyme which catalyzes the final conversion of norepi to epi. Norepi needs to be extruded back out into the cytosol. Again, this is accomplished via your VMAT1. In the cytosol, norepi is converted to your epinephrine via your phenylethanolamine N-methyltransferase, or PNMT. This enzyme is only found in the adrenal medulla. It is for this reason that it is only in the adrenal medulla that you will be able to secrete epinephrine in the sympathetic nervous system. This epinephrine is then stored in your chromaffin granules. It enters this chromaffin granule again via your VMAT1. It forms a storage complex with your chromogranin, norepinephrine, and calcium and some ATP. This forms a storage complex. So, this is a storage vesicle, right? Your chromaffin granule. And it will only fuse and exocytose, fuse with the plasma membrane and exocytose the stored catecholamine only in the presence of one thing, and that is acetylcholine. Okay? Unlike all the other hormones na matotoxic tayo sa pag-memorize ng what stimulates the secretion, what inhibits, here, first of all, walang feedback inhibition dyan. Gets? Wala. And only one thing controls it. It's acetylcholine. Hence, it's the central nervous system or the autonomics. Wala nang iba. Though, if we look at this biosynthetic pathway, what do we see? Aside from sympathetic stimulation, which does activate this biosynthesis of catecholamines, ACTH and cortisol, there, ACTH there, ACTH there, cortisol there, can activate various steps in this synthetic pathway. But nowhere here will you see that ACTH or cortisol stimulates catecholamine secretion. Okay? So pag tinanong ko sa exam, which I do every year, if you look through all the endocrine physiology exams, lagi ko siyang tinatanong, what stimulates the secretion of epinephrine? Kasi gusto ko makita na 100% alam niyo yung sagot. And every year, meron pa rin nagdi-disappoint sa akin. It's not ACTH. Only one thing stimulates its secretion. It's acetylcholine. It is a specialized sympathetic postganglionic neuron. Ha? Okay. The major product of your adrenal gland, in contrast to your other sympathetic postganglionic neurons, is not norepi. The major secretion is epinephrine. Most of its secretion is epinephrine and some amounts of norepinephrine. As you know from biochemistry, and as Dr. Valenzuela should have discussed, your catecholamines are degraded by two enzymes, which are your catechol-O-methyltransferase here, and your MAO, or monoamine oxidase, which progressively degrade your epinephrine to various products, namely your metanephrine, VMA, and normetanephrine, which are excreted into the urine. We can actually measure the levels of metanephrine, normetanephrine, and VMA in the urine if you are suspecting excess catecholamine production. For your catecholamines to exert effects, it has to bind to its G-protein-coupled cell membrane receptors. You know that there are alpha-adrenergic receptors and beta-adrenergic receptors, extensively lectured upon by Dr. Valenzuela. Okay. There are two types of alpha-adrenergic receptors and three types of beta-adrenergic receptors. The actions of your catecholamine hormones you also already know. Depending on which receptor it binds to. Does it bind to a beta receptor, which has greater affinity to epinephrine? Does it bind to an alpha receptor, which some books say have greater affinity to norepi, other books say have equal affinity to norepi and epi. So depending to whether it binds to a beta or an alpha adrenergic receptor, you will get various effects. To simplify, however, catecholamine effects, one, yung obvious, the things you can think of immediately. Fight and flight. You're running away from a dog. You're running away from a dog. Kinakabahan ka. Your heart rate increases, your cardiac output increases, your BP increases. I have to see my enemy, my pupils dilate. I'm running very fast. I'm running very fast. I need to breathe more. My bronchi dilate. So it has a bronchodilatory effect. Okay. I'm running away from the dog. This is not the time to make wee-wee or poo-poo. Okay? So your GI motility decreases, but you contract your sphincters. Your urinary bladder tone and contraction decrease, but your sphincter increases because you hold on to the pee and the poo. Okay. Catecholamines also trigger sweating and also trigger your hair standing on end on your skin. This is your piloerection, brought about by stimulation of your erector pili muscles. In the blood vessels, the effects would differ. If it binds to an alpha adrenergic receptor, this causes vasoconstriction. It binds to a beta receptor, it causes vasodilatation. It also triggers release of renin from the kidneys. Catecholamines are counter-regulatory hormones. They cause you to increase production of glucose. You need this for greater energy, for fight and flight. So basically, this increases glucagon while decreasing insulin secretion from the pancreas, thereby promoting increased glucose. The increase in glucose also is accompanied by increased lipolysis, liberating a lot of free fatty acids, also converted to an increased keto acid formation. Sometimes you may have tumors in your adrenal gland arising from the adrenal medulla. So this is known as your pheochromocytoma, and these are hyperactive adrenal medullary tumors which produce and secrete too much catecholamines. So this tumor arises from the chromaffin cells. They release epinephrine, norepi, or both. Sometimes it can even release dopamine. If you recall the biosynthetic pathway, that's the first step. Second step. Okay. So aside, of course, from the hypertension, you have other symptoms of excess catecholamines. You can figure them out, right? Now, usually, classically, when we think of pheochromocytoma, they used to describe this as episodic bouts of hypertension with these catecholamine symptoms. Bakit? Kasi sabi na magre-release daw yan ng catecholamines, and the catecholamines have a very short half-life. Tapos pag nawala, magna-normalize ulit daw yung BP. Then magsisecrete siya ulit, magkakaroon ng hypertension sa symptoms, then mawawala. But now, increasingly, we see patients who have hypertension all the time, and some of the symptoms that we will be describing. So what are the symptoms of catecholamine excess? Aside from the hypertension, they have sweating, diaphoresis, no? They have a forceful heartbeat or palpitations. You check, they have tachycardia. They have tremors, they have headache, fatigue, exhaustion. They can have abdominal or chest pain. They feel like they're gonna die, and it really feels that way. Because of the shooting up of the blood pressure, they can get visual disturbances. Wait. How do we treat that? You're supposed again to treat it with you're supposed to treat it with adrenergic blockade first. Then once you've prepared the patient, diba, adrenergic blockade, then you replete their volume kasi pag vasoconstricted sila, kulang yung fluid. Once na na-block natin yung adrenergic activity, we replete them with water, then we undergo surgery, which is very, very dangerous. Okay. You have questions regarding the adrenal gland? Application. Back to why I was so angry with that resident. Parang hindi pa rin kinalimutan. No, but there, I have a point, I promise. Okay. So, bakit ako galit na galit dun sa resident na yun? Oh, nandun na yun, hindi ka nagbasa, you cleared the patient, come on. You cleared the patient, you didn't tell me. So, I told her, pwede magbasa ka muna. I need you, as soon as you put down the cell phone, I need you to put down the cell phone, and the first thing you need to do is to go to the ward, write in the chart, and talk to the resident. And I want you to write this, defer surgery. Defer surgery will need to do hormonal workup before clearing the patient from endocrine standpoint. E di syempre natatakot siya kasi inaway na niya yung surgery resident, right? Tapos, na-refer na siya sa anesthesia, they booked the OR already, ready na silang lahat. They bought the needs for the OR. Sabi ko, I don't care. Kasi I don't care what the surgery resident thinks of you, I only care about the patient, which should be your only concern. We're not there to protect each other's assets, though sometimes we do that, we should not. The primary concern is the patient. And I told her, sabi niya, Doktora, is there a way that I can write it in another way? Na hindi niya sinasabi sa akin na hindi siya magmumukhang tanga. Pero basically, yun yung gusto niya mangyari, di ba? So, hindi pwede. Isulat mo doon, disregard previous order. Defer surgery for hormonal workup. And in fact, my recommendation was, you send the patient home. Kasi the BP, di ba, remember, there's just a mass there. Our only thing to prove is it secreting or non-secreting? Kasi kung non-secreting siya, edi okay. Kahit galawin mo siya ng galawin, tatanggalin mo lang naman yung mass. They will not remove the entire adrenal, I hope. Diba? But if they do, at least meron pa siyang kabilang adrenal. And the point is, the only thing you need to know is that tumor secreting or not? Nasa government hospital nga, these hormonal acids are very expensive. Meron na ba siyang funds for those workups? Second, those workups will take time. Some of those workups are only available at certain institutions. And since very costly yung reagents, sometimes they pool. You know what pooling means? Kailangan maraming samples. Maraming pasyente na magpapagawa before they run it. Some, nung panahon ko, pinapadala pa sa Singapore. Tapos pinapadala sa atin, that takes a month. Okay? For that to happen. And so I was telling her, you know, kung ako, that is a government bed. You are depriving someone from the use of that bed. Kasi diba kung iiwanan mo na siya doon para hindi mo, kasi you know, some of these tumors are very rare. And you might not be able to operate on a lot of adrenals if you're a surgeon, diba? If you're training. And maybe they're afraid they're gonna lose the patient. Diba? If you discharge the patient for workup, baka hindi siya sa'yo bumalik. First of all, baka nabuisit na siya sa'yo. Second, might transfer somewhere else. Diba? So, you can't keep the patient there. What if it will take weeks? Diba? You're waiting for the results. You're depriving someone of the bed. You're using government funds. And lastly, you're keeping him there, baka magkaroon siya ng hospital-acquired infection. So discharge him. Ang galit ng surgery. So nagpatawag sila ng multidisciplinary conference, guest na naman ako. Diba? Pero I know I'm right. But the thing is, the reason the surgery resident, na by the way, consultant na ako resident, siya kaklase ko siya nung pre-med. Diba nakakatawa? Okay. Asama ko. Okay. Okay. Surgery resident. Kasi nabuntis siya eh. Sige. Resident siya, senior resident at the time. They were not angry that we had deferred. They knew exactly that we needed to work up. Na-shock nga sila na we didn't order any work up. They were angry because they had admitted the patient, had asked them to buy the stuff. Tapos here we are, not me, her. She is. Here she is. Here she is. Telling them suddenly to defer. So talaga nagalit. So during the session, they were saying we're not actually angry about that. We're angry. So, oh, well, yes, she's wrong. Diba? Why is she wrong? Ano bang pwedeng mangyari? Oh, yung pinaka-obvious na lang. If that is a pheochromocytoma, mere touching, ganyan lang ah. Manipulating that tumor releases all the catecholamines. Remember, you didn't give any adrenergic blockade. Wow, hypertensive emergency. And if your anesthesiologist is unprepared, wala siyang emergency meds. Kasi you need to give an IV beta blocker. And let me tell you right now, wala na kaming IV beta blocker available in the Philippines. Di ko nga alam how we survive. Wala na kaming IV beta blocker. How will we survive? Then, sabihin natin she survives. You were touching it, manipulating it, you released all the catecholamines. You remove it. Ang half-life ng catecholamine is seconds to minutes. Right? Pag nawala siya, what happens to the baby? So suddenly, dapat may ready kang inotropic, synthetic norepinephrine. Are you ready? You're not ready. Sa amin nun, if there's a pheochromocytoma, all the fellows we go in. Parang one nga lang yata yung nakita ko. It's rare. And it's very dangerous to operate on it, even if you're adequately prepared. And the way we prepare, first, we block the alpha adrenergic receptors first. Then we block the beta receptors next. Do you know why? What did I say about the effects of alpha and beta in the blood vessels? Alpha mediates vasoconstriction, and the beta mediates vasodilatation. Sometimes, if you do not do alpha blockade, adequate alpha blockade first, and you decide, I'm just gonna give a beta blocker, nawala yung vasodilatory, you remove the vasodilatory effect, panay vasoconstriction na lang yun. Paradoxically, you will get a hypertensive emergency. But it's just physiology. Hindi natapos yun, ano. So there, so you give alpha blockade, this will take weeks. Then a beta blockade, then you admit them, you rehydrate them, and then paparedy natin lahat ng gamit just in case for the surgery. Madali? Hindi. Pero di niya alam yun eh. Tumawa. Diba? It's so frustrating, nakakatawa na nakakainis, diba? Okay. What if it's a Cushing syndrome? Oh, ano ba naman yun? Excess yung cortisol. Eh di ma'am, di maganda, diba? You remove the cortisol, okay lahat, the problems are solved. No. Because if you have excess cortisol brought about by that adrenocortical tumor, oh, mataas ang cortisol natin. The ACTH goes, oh hala. The cortisol is high, your ACTH is low. Remember, there's no storage pool for your cortisol. Once na ma-deplete lahat ng cortisol mo doon. And your ACTH will remain suppressed for about 9 to 12 months. Okay? It will remain suppressed for 1 to 12 months. Is there a storage pool for cortisol in the remaining adrenal gland? No. If you do not give synthetic glucocorticoids through the IV, wala ka ng cortisol pagkatapos nun. And your patient will die from adrenal insufficiency. Sino may kasalanan? Ikaw pa rin. Diba? O meron siyang excess adrenal androgen, okay lang. Okay? Nothing will happen. If you have excess aldosterone, well, first you have to deplete the potassium. You have to recognize that the potassium is normal. Once the potassium is normal, then you go. Because otherwise, you can have arrhythmias. Sino may kasalanan? Ikaw pa rin. So in short, anong big sabihin nun? First, develop professionalism. Diba? When a patient is referred to you and you don't know, don't write anything yet. This is not a contest and you're not being timed as to how fast you answer a referral. Meaning, pagpunta mo doon, sulat. Paano kung mali-mali naman pinagsusulat mo? The patient will die and you will look stupid. You will be sued. You may lose your license. Such things. Diba? You look, you're not sure, huwag ka magsulat. Pumunta ka sa office, magbasa ka. Then, bumalik ka. At the very least, know some basic things. She does not know basic things. Hoy, doktor na siya ngayon. Internist na siya ngayon, geriatric specialist siya. Nasa States. Diba? So, kakatakot, no? I mean, you know, those are the things. You develop professionalism. By the way, professionalism includes coming on time. Do you know that if you have a surgery at 8 o'clock, you have to be there by 7? Because if you do not come at 7, madidelay yung OR mo. Pag na-delay yung OR mo, tumatagal yung NPO ng patient mo. Pag na-delay yung OR mo, the next OR madidelay. Siya, late din siya dumating. Kasi wala rin siyang professionalism, di ba? Pag late siya dumating, madidelay yung OR niya. Pag na-delay yung OR niya, yung susunod na OR, lahat yung madidelay. Such that the last OR may not push through. But hey, it's just punctuality. Diba? Diba? I mean, you know, there are certain things, I think, that you learn in the first year of medical school that you develop through time. Physiology is one of them. Professionalism is the second one. Diba? May tanong kayo aside from the fact na kailangan kayo on time. You know, kasi ganito, no? Ngayon ko na kasi dami ko pang oras, so consuming ko pagkalitan kayo, no? Kasi this is the way I think. You come on time, right? Kasi sa lahat ng pictures ko, dinadocument ko kung gaano karami kayo at 7:50 eh. And again at 8 o'clock. Gusto ko, not for any purpose, for my own curiosity. Okay? Do I always start on time? Yes. Kahit isa lang nandito, I will start on time.